for allowing me to present today. I am very honored to be here, and I will be presenting Antepartum Maternal Depression Screening and Education with a focus on health disparities. So first, I'll tell you a little bit about myself. Okay, I'll start with my introduction. Then I'm going to move into discussing maternal depression, health disparities, and then at the end, because I know I do have a short time frame, I'm going to give you a condensed version of my PhD dissertation that was built off of my experience as maternal child nurse. So a little bit about me. I've been in maternal child nursing for about 17 years. I'm really dating myself, right? But that has been a combination of clinical nursing and within academia. Since 2015, I've been an assistant professor here at University of South Florida College of Nursing here in sunny Tampa, Florida. Also in relation to my experience, I am on the editorial advisory board for the Association of Women's Health, Obstetric, and Neonatal Nurses. Sorry, of course, I'm feeling under the weather today, of course. But what's really exciting is this presentation that I'm about to begin. It actually comes with these two refereed publications that I have. I've actually published on this topic twice, which is really exciting for me. A little bit more about myself. These are just some of the honors and awards that I received while teaching at the University of South Florida, starting all the way with my clinical excellence, my excellence in simulation, and also very honored to receive the Distinguished Faculty Award, which is an award that is voted upon with our students, which is really exciting. All right, so just a discussion about maternal depression. And I'm gonna have to, let me see here if I can move or shrink myself. There we go, much better. Okay, so maternal depression, and I know a lot of people have heard more of postpartum depression, but I really want to focus on antepartum depression as well, which is very important. So antepartum depression is depression occurring during pregnancy, and it's associated with poor self-care, decreased motivation to seek help, as well as a negative perception of the benefits of obstetrical care. In postpartum depression, that's depression that can start at any time in the first few months after giving birth, and common signs and symptoms are sadness, hopelessness, guilt, or worthlessness. So statement of the problem, let me see if I can still, trying to shrink myself. It's covering my entire screen. There we go. Okay, perfect. Let's move this over, sorry. There we go, I'm completely hidden. Love that, okay. So statement of the problem. So antepartum depression is recognized as one of the significant risk factors for postpartum depression. And pregnant women are not adequately receiving antepartum maternal depression screening, also antepartum maternal depression education. So knowing that pregnant women with antepartum depression will most likely have postpartum depression, why not try to identify it as soon as possible? That's the question I really asked myself. Studies have shown that antepartum depression could lead to poor prenatal care, leading to the possibility of preterm labor. In addition, the earlier that postpartum depression is identified and treated, the less likely there will be adverse effects or that it will turn into postpartum depression and psychosis. Pregnant women without chronic depression or depressive symptoms are primarily receiving depression screening during the first trimester and then 6 weeks postpartum. So this yields an approximate 10-month gap between screenings. Unless a pregnant mother comes forward and discusses her symptoms of depression, she may fall into this 10-month gap. In addition, antepartum and postpartum depression education is lacking within the antepartum period. So if a woman is expected to identify her symptoms of depression in order to be screened by her healthcare provider more often, well, then we need to teach them what to look for. We need to give our pregnant moms a voice. In addition, with health disparities, most women at risk for antepartum depression were also associated with a health disparity. It is a health difference that is closely linked with economic, social, or environmental disadvantage. And health disparities denote a specific kind of difference, namely worse among socially disadvantaged people and members of disadvantaged racial ethnic groups, and economically disadvantaged people within any racial or ethnic group. The highest prevalence was among American Indian, Native Alaskan, Hispanic, and African American women. In addition to the screening, African American, Asian, and non-white pregnant women are less likely to be screened. Also, there were lower rates of screening observed in those who were insured with Medicare, Medicaid, those that were younger than 24, or were non-native English speakers. These disparities are especially concerning because low-income and African American women are more likely to experience antepartum depression than any other ethnic group and are missing out on much-needed screening and opportunities for early intervention. And as I mentioned, overall, antepartum maternal depression education is lacking. And that's really where I started before my dissertation, is really looking into what kinds of prenatal care is out there. We have group prenatal care, individualized prenatal care, but there was still this lacking of education on antepartum depression, and there was more of a focus on postpartum depression. So just a quick, like I said, synopsis of my study, since I do have a short amount of time, I'll give you the shortened version. But I graduated from the University of Florida in 2019. This was the study that was very successful, titled Testing Medical and Nurse Practitioner Students' Knowledge, Self-Efficacy, and Motivation for Antepartum Maternal Depression Screening and Education. A real mouthful, right? But the purpose of my study was to test medical and nurse practitioner students' pre and post intervention knowledge, self-efficacy, and motivation for antepartum maternal depression screening and education. Obviously, being in academia, I thought it was really important to kind of start with our students first. Once I can conduct my study with students, then I can actually utilize healthcare providers in current practice. So that was my decision for choosing students. And the significance. So having this standardization of maternal depression screening and education in each trimester during the antepartum phase of pregnancy will enhance self-identification of symptoms, may also increase additional depression screenings in between the set standard screenings, and it could lead to the prompt treatment of maternal depression throughout pregnancy and postpartum. So my methodology, I utilized medical and nurse practitioner students. They were recruited by convenience sample at the University of South Florida, College of Nursing and College of Medicine, once again wanting to look at physicians and nurse practitioners. The target sample size was 80 students. The students were approached in a group setting during their didactic course, and it was really exciting. I went to their course, I explained my study, and it was really amazing how quickly I received participants. They were all very excited to join my study. Once they decided to join my study, obviously I consented them, and I assigned them a de-identified number, and they received the REDCap study link. For those of you that don't really have a lot of experience with REDCap, it's our research electronic data capture, and it's such an amazing platform where I could actually upload my entire intervention, all of my surveys, everything into this one platform. After I gave them the link, obviously I had to instruct them how they would log in, how they would complete the study, and I really wanted them to do it in one sitting. I wanted them to log into REDCap. I wanted them to do my surveys, utilize the intervention, and then immediately do the post survey. I didn't want it to be something that they would have to log in multiple times, because that's obviously could cause attrition. So I wanted it all done in one sitting. This was the conceptual framework that I utilized for my study. I utilized Kolb's experiential learning theory. This was based for my knowledge variable. And it was really important. Kolb's is really kind of based in that concrete experience. So you kind of start with that. Then the students kind of go through reflective observation. Then they go through abstract conceptualization. And then it leads to active experimentation. And this was really what I wanted to focus on with this 4-step process as I was navigating through my intervention, looking at my knowledge variable. Bandura's theory of self-efficacy believes in extrinsic experience. So the students bring their own experience, their own self-perception. They go through this period of observational learning, and then they end with what's called social experience. And then I had the self-determination theory of motivation. And this is really amazing. It suggests that the more autonomous forms of motivation give rise to the higher effort in actions. So if one feels more autonomous and they feel more competent and they have relatedness, that will increase their motivation. So if you look here at the top here, all of my theories, they were mediators that acted as causal antecedents to my pre-intervention, when I was looking at knowledge, self-efficacy, and motivation. In the middle, you'll see there that student profession is the moderator. And then my online intervention would mediate my actual post-intervention scores. Once again, I wanted to look at both groups of students because obviously they both will be taking care of our pregnant patients. My online PowerPoint presentation that I gave them within the intervention had content validity. I actually received 100% inter-rater reliability. The PowerPoint presentation was about 15 minutes in length, and it was really important for me to have different methods of teaching. So there was visual cues, obviously there was audio, and then tactile. As they went through some of the PowerPoint, they actually had to click and answer some questions as they went throughout. My intervention was based on EMONC, which is the Emergency Obstetric Care and Early Newborn Care. And my major topics that I included were antepartum and postpartum depression. I included all the signs, symptoms, screening, and treatment. Obviously, also having that caveat to really focus on health disparities. I included antepartum maternal depression education, highlighting the importance of understanding patient health literacy, because that's another very important aspect. All right. Obviously, I want to standardize care. I want screening and education happening in every single trimester for all pregnant women, not just those that screen positive or those that have high risk factors. I really wanted for all pregnant women, okay? Well, it's really important for our students to understand, right? And obviously, and eventually our providers in practice, is that we do have to focus on health literacy, because even though I want to standardize this, we still have to be able to individualize it based on our patients' health literacy. And then in conclusion, I ended with just kind of giving them an overview of the difference between postpartum blues versus postpartum depression. So I had a little section on that as well. The measures that I utilized for my demographics, I gave them a questionnaire. So as soon as they logged into REDCap, this questionnaire was the first thing they could click on, and it was for student type. They put in their age, their gender, their race. And I also thought it was really interesting, and I wanted to add in there if they had any children. You know, thinking about this type of study, looking at, you know, antepartum and postpartum depression, I was really curious to see, do my participants, do they have children? You know, maybe they do come in with some background knowledge. So I thought that was really interesting. And then my pre and post intervention. So they had the demographic questionnaire populate. Then they did these pre-interventions here with all the evaluations, and then they did it after the PowerPoint as well. My knowledge tool that I utilized was really, really amazing. It's called Speak Up When You Are Down, the Postpartum Depression Awareness Campaign. And also there was a section within the campaign that did address antepartum depression, because obviously I wanted to discuss both. And then these other tools that I utilized, and it was so interesting. So as a PhD student, obviously I'm trying to find, you know, the perfect means to evaluate self-efficacy and motivation, right? I want to see, you know, how they feel about education and are they motivated to educate? And I found these two tools, the PTSQ and the PTMQ. They were developed by Dr. Christoph Dybowski, who's from the University of Hamburg-Eppendorf in Germany. And here I am in Florida, emailing this professor in Germany, asking if I could utilize these tools, obviously adding a little bit of a different caveat, being able to kind of adjust it to work for students as well. And to my surprise, within, I would say, a week, Dr. Dybowski reached out to me and he was like, absolutely, you can utilize them. And he was really excited. And it's just been a really great working relationship, because even after my study was completed, I reached out to him and gave him the results, and we had a great conversation. So it was just really amazing, because you kind of send this email out into the world and he responded. And it was really, really amazing. but I did alter them just a little bit. And I called the first one the physician, nurse practitioner, student teaching self-efficacy questionnaire. So they answered that. And then the motivation one was the physician, nurse practitioner, student teaching motivation questionnaire. So at first they were directly for physicians, but it allowed me to actually kind of edit them a little bit to add a nurse practitioner and then the caveat to utilize with students as well, which was exciting. This was a statistical analysis that I utilized. I utilized a 2x2 mixed factorial design. I was looking at in between and also within my subjects. I had 2 levels. I had medical and nurse practitioner students, and I had a repeated measures which occurred at 2 time points, which was pre and post intervention. Okay, so we'll go to my results. I can see here that I'm trying to go quickly here. It's kind of hard to condense it, but we're going to do it. So next, here are my demographic characteristics. You can see here that I have all my demographic variables. That was all related to the questionnaire when they first logged into REDCap. In total, I had 71 participants that completed the study. There were 52 nurse practitioner students and 19 medical students. My chi-square test, as you can see there, was utilized, and I wanted to compare my demographic measures between nurse practitioner students and medical students. And as you can see with the results there, that the distribution of all my demographic variables were pretty much equal between medical and nurse practitioner students. Medical and nurse practitioner students were primarily white, and medical students tended to be younger than nurse practitioner students and were more likely to be male and less likely to have children. So these were the descriptive statistics of my outcome variables. As you can see here, my means are very similar. But what I found really interesting is that medical students, they had greater pre-knowledge for maternal depression than nurse practitioner students. But nurse practitioner students, they had a greater pre-self-efficacy and motivation for patient teaching. And you can even see that in the literature when we kind of go through the literature and look at patient education, patient teaching. There is a lot of data regarding nurses and nurse practitioners completing patient education. So it's really interesting to see that here as well. My repeated measures. So obviously this is my pre and post that I utilize, pre and post intervention. So looking at student profession, I had to fail to reject the null because my group means for self-efficacy, motivation, knowledge, they were all very similar. So student profession really was pretty much the same results for both. But the time I did reject the null, and I did conclude that both groups had a change in knowledge, self-efficacy, and motivation over time, which was really exciting to see. But I did fail to reject the null for my actual medical nurse practitioner time by student, because really, once again, my student profession, which I found a little surprising for me. I thought I might see a little bit of a difference between nurse practitioners and medical students, but I really didn't. They all pretty much performed very similarly, and they all had a similar score pre and post intervention, which was really interesting. And then my discussion here. So my summary of my results, as I mentioned, the group means were similar between medical and nurse practitioner students on all 3 of my dependent variables. They both had an increase in mean knowledge, self-efficacy, and motivation over time, but student profession did not moderate this change in time. So implications for education. So utilizing this data, I really would like to take a closer look at the curricula for nurse practitioner and medical students. I could actually utilize this online intervention within the curricula, which is really exciting. Implications for clinical practice. It's really exciting that, I did have this increase in knowledge, self-efficacy, and motivation. So this has actually been sort of a buy-in to bring this to the bedside with practicing health providers. USF has a really great relationship with USF Health. So I'm actually in the works of bringing this intervention into practice and doing a study with the providers to kind of see their feedback and hopefully create this standardized process, which is really exciting. Implications for future research. I definitely in the future, like I said, I want to work with nurse practitioners, physicians. And I think what would really help is if I were to branch out. So yes, we do have that relationship with USF Health, but it would be wonderful to go within Hillsborough County and our community to many different types of providers, different clinics, and try to also promote this standardized teaching and screening to them as well, to really kind of enhance also that external validity. I think I'm right at time. Sorry, I kind of quickly try to go through that. But that's just a little bit about what I've been working on, and it's been really, really exciting. If you have any questions, I'm happy to answer them. I know I just kind of went through, sorry, I went through that a little bit quickly, but in 20 minutes,